Welcome to the Deep Dive, where we take your stack of sources and help you uncover the most important insights. Today, we're plunging into a fascinating set of notes you've shared, zeroing in on some really essential concepts in pharmacology and health.
That's right. Yeah, this material covers quite a range from how medications fundamentally work, against bacteria or viruses to spotting potential problems like drug toxicity and understanding some key preventative measures too.
Think of this as a focused expedition, really, through your notes. We want to get you quickly oriented and well-informed on the key ideas. We're talking antibiotics, antivirals, bone health, quite a bit more. Our mission: unpack these concepts, pull out the crucial details, and just make sure you walk away with a clear grasp of what's really important here.
Exactly. It's about boiling it down to the core knowledge, the mechanisms, the red flags, the things you need to explain to patients. That's what makes this information truly useful.
Yeah, and we've got a lot to explore. Things like why certain infections like C. diff can take hold after antibiotics, what signs screen danger with drugs like aminoglycosides or, say, methotrexate, and the really crucial how and why behind taking meds like tetracycline or alendronate. Exactly right. Plus, how vaccines protect us, and even just clarifying some terms that pop up in these notes like paresthesia or alopecia.
It's a dive into the practical knowledge sort of embedded right in this material.
Okay, let's unpack this deep dive into your notes and get started.
Yeah.
So, kicking things off, antibiotics. Huge topic.
Hmm.
Your notes start right at the cellular level, mentioning they inhibit things like cell wall synthesis, protein synthesis, DNA processes, and bacteria. And there's this core distinction mentioned: bacteriostatic versus bactericidal. Can you help us understand the practical difference there?
Yeah, that distinction is, well, it's fundamental. Think of bacteriostatic antibiotics like putting the brakes on bacterial growth. They stop the bacteria from multiplying. Basically, they hold them in check.
Okay, so if the drug isn't actually killing them, how does the infection clear up?
That's where your own immune system comes in. It's the body's natural defenses that then go in and, clean up or kill off the bacteria that the drug has stopped from reproducing.
Got it. So the drug kind of handicaps the bacteria, and your immune system lands the final punch. What about bactericidal then?
Bactericidal drugs, they're the direct killers. They actively destroy the bacteria. They are lethal to the organism, often by damaging essential structures like that cell wall or just messing up vital processes so bad that they can't recover.
Okay, that's a pretty clear difference in approach. Now, your notes highlight aminoglycosides like gentamicin. Powerful stuff, but they also come with specific risks. What are the absolute critical signs of toxicity we need to be watching for with those?
Right. With aminoglycosides, you absolutely have to watch for signs related to the ears and the kidneys. Those are the big ones. Key signs of inner ear damage, that's ototoxicity, include things like dizziness or vertigo, that persistent ringing in the ears we call tinnitus, and changes in hearing. That can actually progress to permanent loss.
Wow.
Balance problems, too. They're common because it affects the vestibular system.
So really listen closely to any complaints about hearing or balance. That's key.
Exactly. And then on the kidney side, nephrotoxicity, you're looking for changes in urination, how much someone's peeing, any swelling, or other signs of kidney distress. These are serious. You need immediate attention. Other less common things, maybe muscle weakness, a rash, fever, just general fatigue.
Yeah.
Those are possible, too.
That really underlines why monitoring is so vital with those drugs. Okay, shifting gears a bit, macrolides are mentioned next. How do they work, and what's that specific binding mentioned in the notes?
Macrolides drugs like erythromycin, azithromycin, they also target bacterial protein synthesis, but they do it differently. They bind to a specific part of the bacteria's protein-making machinery. It's called the 50S ribosomal subunit.
Okay, 50S ribosomal subunit.
Yeah.
Help us picture that. What does binding there actually do?
Okay, imagine the bacteria's ribosome as like a tiny factory, right? Assembling proteins on an assembly line. The 50th subunit is a key piece of that line. Macrolides bind there and basically block a crucial step on this assembly line. It's called translocation. This step is needed to add new building blocks to the growing protein chain. So by blocking it, the bacteria just can't build the proteins they need to grow and function.
So it messes up their internal manufacturing line. Does that generally mean they're bacteriostatic then? Like the ones that just inhibit growth?
Yes, generally macrolides are bacteriostatic. They stop the bacteria growing by messing with protein production. Your notes also point out a really common teaching point about macrolides in food.
Right, usually take them with food to lessen the GI upset, which is a common side effect. Except for a few, like azithromycin, where absorption is actually better on an empty stomach. Huh.
Ew!
That stomach irritation is one thing, but the notes link esophageal irritation to a different class.
Absolutely, tetracyclines. They're notorious for that. And this is a critically important teaching point because if you don't take them correctly, they can cause really severe irritation, even ulceration of the esophagus.
And the instructions for tetracycline are pretty specific, aren't they? Take it on an empty stomach an hour before or 2 hours after meals. And you absolutely have to avoid dairy, antacids, and iron supplements for like 2 hours around the dose.
That avoidance part is crucial because things like calcium, magnesium, iron, aluminum, you find those in dairy, and those supplements, they can actually bind to the tetracycline right in your gut. They form this complex the body just can't absorb, so you don't get the medication working properly. The empty stomach helps with absorption, yeah, but the esophageal risk. That's why the notes stress taking it with a full glass of water.
A full glass.
And remaining upright for at least 30 minutes. Sometimes even 60 is recommended.
So staying upright is specifically to make sure the pill actually clears the esophagus quickly and doesn't, get stuck or dissolve there.
Exactly right.
The notes mention dangerous esophageal burning could show up as severe pain or difficulty swallowing. That sounds like something you'd need to report immediately.
Definitely. Severe or persistent pain, especially any chest pain or trouble swallowing after taking it, that's a major red flag. Needs prompt medical evaluation.
Okay. Beyond the GI upset and this significant esophageal risk, your notes dig into other adverse effects of tetracycline. What else is listed?
Well, beyond the common stuff, there's photosensitivity makes you much more likely to get sunburned. And in kids, the really big one is dental discoloration and enamel hypoplasia. Basically permanent tooth staining.
Oh, right. That tooth effect is why tetracycline is generally avoided in young children, isn't it?
Yes, precisely. The notes also mention potential liver damage, vestibular toxicity causing dizziness, and even a rare kidney issue, Fanconi syndrome. But that's mostly linked to older, outdated formulations. It's a drug with quite a range of potential issues.
Wow, definitely a lot to keep in mind there. Let's switch over to fluoroquinolones. Your notes specifically list medications you should avoid taking them with.
Yes. Fluoroquinolones, like ciprofloxacin or levofloxacin, they share a similar absorption problem with those metal ions, just like tetracyclines. So you need to avoid taking them with antacids, multivitamins, or any supplements containing magnesium, aluminum, calcium, iron, or zinc. Space them out.
So same deal, binding, preventing absorption. But the notes highlight another combination to absolutely avoid corticosteroids. Why is that?
That's a critical interaction. Combining fluoroquinolones with corticosteroids significantly ramps up the risk of tendon damage, specifically tendinitis, which is inflammation, but more dangerously, actual tendon rupture.
Rupture. Ouch.
Yeah. Fluoroquinolones already carry this risk on their own. It's a notable toxicity for the class, but adding corticosteroids makes that risk much, much higher.
Tendon rupture sounds incredibly debilitating.
Yeah.
And speaking of really serious issues, your notes mention Stevens-Johnson syndrome, or SJS. What exactly is that, and how serious are we talking?
SJS is a severe, potentially life-threatening skin reaction. It's basically an immunological response where the top layer of your skin starts to detach from the lower layers. It looks like painful red or purplish skin that blisters and then peels off. It often affects large areas of the body and, critically, the mucous membranes, mouth, eyes, genitals.
That sounds also like a full-body, severe burn.
It effectively is, in terms of the damage and seriousness. It's an absolute medical emergency. It requires immediate hospitalization, often in a burn unit or ICU. The notes are really clear. If you even suspect SJS, it needs immediate medical attention and must be reported to the provider right away. It's not something you wait and see about.
Immediate action. Got it. Okay, let's pivot slightly to understanding infections themselves. Your notes define superinfection. What is it, and how does taking an antibiotic actually lead to one? Seems counterintuitive.
It does seem odd, right? A superinfection is essentially a new infection that pops up while you're being treated for a primary one, or maybe shortly after you finish the antibiotic. It happens because the antibiotic you're taking for the first problem, well, it disrupts the natural balance of microbes living harmlessly in your body, particularly in places like your gut, mouth, or vagina.
So the antibiotic kills off the good, or maybe the neutral bacteria that were keeping potential bad guys in check.
Exactly. Without that competition from the normal flora, other organisms like certain bacteria or fungi that happen to be resistant to the antibiotic you're taking, they can suddenly overgrow and cause a whole new infection. Your notes list some classic examples.
Like Clostridioides difficile, C. diff, colitis.
Yes. C. diff is a really common one, especially in hospitals or long-term care after broad-spectrum antibiotic use. It overgrows in the colon, produces toxins, and causes severe, often really debilitating diarrhea.
And another example is candidiasis.
Right. Fungal infections caused by Candida species. Oral thrush, that white coating in the mouth, or vaginal yeast infections are very frequent superinfections people see after taking antibiotics. Your notes also list MRSA infections as potential superinfections sometimes. For the same reason, killing off competitors allows resistant MRSA to flourish.
In your notes, link oral thrush specifically to the drug nystatin.
Yes, nystatin is a very common antifungal medication used specifically to treat candidiasis, whether it's oral thrush, maybe fungal diaper rash, or even intestinal candidiasis sometimes.
And while we're on antifungals, what are some potential organ toxicities we need to think about with this class in general?
Antifungals, especially the systemic ones, the pills or IVs, can potentially cause liver toxicity, which we call hepatotoxicity, and also kidney toxicity, nephrotoxicity. It's why monitoring liver and kidney function tests is often part of the plan when someone's on a longer course of these medications.
So, kidney toxicity again.
Mm-hmm.
That's a theme popping up with different drug classes. Okay, switching to a really fundamental question. How do healthcare providers choose which antibiotic to use? There seem to be so many options.
It's definitely a multi-step process to get it right, ideally. Initially, they often make an educated guess. We call it empirical therapy. It's based on the most likely bugs for the type and location of the infection, plus the patient's symptoms and history. They might start with a broad-spectrum antibiotic, one that covers a wide range of possible culprits.
Okay, start broad, cover the bases, then refine.
Precisely. The really crucial step, whenever possible, is taking a sample, could be blood, urine, tissue, a wound swab, whatever is appropriate, and sending it to the lab. The lab does a culture to identify the specific bacteria causing the trouble. And then, importantly, they do sensitivity testing. This tells you which antibiotics are actually effective against that particular bug.
Ah, cultures and sensitivities, C and S. That sounds like the key to moving from, well, guessing to actually targeting the right enemy.
Exactly. Once those results are back, the provider can often switch to a narrow-spectrum antibiotic, one that specifically targets the identified pathogen. This is much preferred because it's usually more effective, less likely to disrupt your normal flora, reducing that superinfection risk we talked about, and it also helps slow down the development of antibiotic resistance globally.
That makes a lot of sense, that whole strategy.
Yeah.
Okay, let's switch gears entirely now to antivirals. How do they work? It feels like a completely different challenge than bacteria.
It absolutely is. Unlike bacteria, viruses aren't really independent organisms you can just kill outright by, say, smashing their cell wall. Viruses are basically just bits of genetic material that hijack your own cells to reproduce. So antivirals work by interfering with different stages of that viral life cycle inside your cells.
So they block the virus from taking over or reproducing using your own cell's machinery.
Yes, exactly. They might block the virus from even getting into the cell in the first place, or stop it from copying its genetic material, its DNA or RNA, or prevent it from making the proteins it needs, or even mess up the assembly and release of new virus particles from the cell. Your notes mention acyclovir as an example.
Right. What does acyclovir do specifically?
Acyclovir is designed to inhibit a viral enzyme called DNA polymerase. This enzyme is absolutely essential for the virus to replicate its DNA. So by blocking it, acyclovir effectively stops the virus from making copies of itself, which halts the infection's spread.
And what kinds of infections is acyclovir used for typically?
It's primarily used for infections caused by herpes viruses. That includes herpes simplex types 1 and 2, think cold sores, and genital herpes, and also varicella zoster virus, which is the one responsible for chickenpox and shingles.
Okay. Your notes also list zidovudine as an antiviral, but specifically an antiretroviral. That sounds like it targets a different kind of virus altogether.
It does. Zidovudine, often known as AZT, was one of the first critical medications used in the treatment of HIV. HIV is a retrovirus. That means it uses a special enzyme called reverse transcriptase to convert its RNA genetic material into DNA. It then integrates that DNA into the host cell's own DNA. Zidovudine is what's called a nucleoside reverse transcriptase inhibitor, an NRTI. It specifically blocks that reverse transcriptase enzyme.
So it stops HIV from basically splicing itself into your genetic code.
Got
it. What are the key side effects to watch out for with zidovudine?
Well, common ones include things like headache, nausea, just feeling tired. More serious concerns involve bone marrow suppression, similar to what we discussed with methotrexate. This can lead to anemia, which is low red blood cells,
Right.
neutropenia, low white blood cells, which increases infection risk, and potentially something called lactic acidosis with liver enlargement, which is a more severe metabolic problem.
Bone marrow suppression definitely seems like a recurring risk with some of these powerful drugs.
Yeah.
Your notes also touch on HIV prevention with pre-exposure prophylaxis. What are the really essential teaching points for someone taking pre-P?
The absolute core message for pre-P is consistent daily adherence. It's only effective if taken every single day as prescribed. Consistency is absolutely key. It's also vital to reinforce that pre-P only protects against HIV. It does not prevent other sexually transmitted infections, so using condoms is still really important for comprehensive protection.
Okay.
And regular follow-up appointments, usually every 3 months, are necessary. That's for HIV testing to make sure the person hasn't become infected, and also for monitoring kidney function, as some pre-P medications can potentially affect the kidneys.
Daily consistency, understanding its limits, and regular checkups. Got it. Let's look at a general concept about medication timing mentioned in your notes. Some drugs need around-the-clock dosing, while others are fine just during daylight hours. Why is that timing so crucial sometimes?
Yeah, it primarily relates to keeping a stable therapeutic concentration of the drug in the bloodstream. For serious infections or maybe chronic conditions where you need continuous suppression of a pathogen or constant management of a disease, think certain antibiotics for severe infections or maybe meds for epilepsy, you need to keep those drug levels steady, 247. That means dosing strictly every 8 hours or every 12 hours, right around the clock, even if it means waking up.
Right, to keep the concentration consistently within that effective window, not letting it drop too low.
Exactly. On the other hand, some medications might have a very long half-life, meaning they just hang around in your system for a long time after a single dose, so once daily dosing is perfectly fine. Or, they might be for symptom relief, taken only when needed, so the timing isn't about maintaining a constant therapeutic level at all.
That makes sense. You wouldn't take a pain reliever around the clock if you only hurt during the day, right?
Precisely.
Okay, let's shift again to another area in your notes. Bone health and related conditions. How is bone density typically measured? What's the standard test?
The standard test, the gold standard really, for measuring bone density and diagnosing conditions like osteoporosis is a DEXA scan. That stands for dual energy X-ray absorptiometry.
DEXA scan. Okay.
Yeah.
And your notes mention calcitonin. What is the action of that hormone? What does it do?
Calcitonin is a hormone primarily involved in calcium regulation in the body. Its main action is to lower blood calcium levels. It does this largely by inhibiting bone resorption. That's the process where specialized cells called osteoclasts break down bone tissue and release calcium into the blood.
So it basically puts the brakes on the process that releases calcium from bone.
Correct. And speaking of preventing bone breakdown, bisphosphonates are a major class of drugs used to treat osteoporosis. Your notes mention a common ending for drugs in that class.
Oh, yes. They typically end with L-jornate, right? Like alendronate.
It's exact versionate.
And with alendronate, the patient teaching points are absolutely critical because of that esophageal risk we talked about earlier with tetracyclines. Remind us of those crucial instructions.
Yes, these instructions are vital to prevent serious esophageal damage. You must take alendronate on an empty stomach first thing in the morning with a full glass of plain water. Just water, nothing else. And the absolutely non-negotiable part, you have to remain fully upright. So sitting or standing, no slouching, definitely no lying down for at least 30 minutes. And some sources even recommend up to 60 minutes after taking the pill.
Wow. Okay.
And don't eat or drink anything else during that time either.
So empty stomach for absorption, full glass of water, and staying upright to make sure it passes quickly through the esophagus and doesn't get stuck or cause irritation.
Precisely.
And severe pain or difficulty swallowing after taking a bisphosphonate. That would definitely warrant immediate medical attention. As the note suggests, it could signal dangerous esophageal burning.
Absolutely, a red flag. Your notes also link bisphosphonates to a vitamin deficiency issue, don't they?
Yes, they highlight the importance of vitamin D adequacy. Can you explain that connection?
Sure. While bisphosphonates work by slowing down bone breakdown, you still need enough calcium and vitamin D for your body to actually build and maintain healthy bone structure. If you're vitamin D deficient, your body can't properly absorb the calcium you consume from your diet or supplements, even if you're taking enough.
And vitamin D deficiency is the underlying cause of osteomalacia, which is the softening of the bones. So these pieces, vitamin D, calcium, bone breakdown, bisphosphonates, they're all interconnected, part of a system.
Exactly, it's all linked. The notes mention that dietary sources of vitamin D include things like fatty fish, fortified dairy products, and importantly, exposure to sunlight helps your body make it. For calcium supplements, they suggest taking them with meals for better absorption. Common over-the-counter forms are calcium carbonate and calcium citrate. Calcium chloride is different, usually used in IV preparations in hospitals.
Okay, bone health covered. Let's transition now to autoimmune conditions. Your notes introduce disease-modifying antiemetic drugs, or DMARDs, particularly for conditions like rheumatoid arthritis. What's the key goal of DMARDs, and how is it different from just taking, say, a pain reliever?
That distinction is really key. While drugs like NSAIDs, nonsteroidal anti-inflammatories, or corticosteroids can help manage the symptoms, like the pain and inflammation of rheumatoid arthritis, DMARDs have a fundamentally different objective. Their goal is to actually slow down or even stop the progression of the disease itself.
Ah, okay. So they're not just masking the symptoms, they're targeting the underlying disease process that's actually causing the joint damage over time.
Precisely. They are designed to modify the disease course, hence the name. They generally work by suppressing or altering the immune system activity that's mistakenly attacking the body's own tissues, like the joints in RA. This is contrasted in the notes with NSAIDs like naproxen and corticosteroids, which mainly provide symptomatic relief from pain and inflammation, but don't stop the disease from getting worse long term.
Right. And we know NSAIDs like naproxen can cause significant stomach issues, right? Indigestion, upset stomach, potentially ulcers, especially if you take them on an empty stomach. The notes point out that persistent indigestion with an NSAI shouldn't just be ignored. It could be a sign of serious GI irritation and needs checking out.
Absolutely. That symptom definitely warrants follow-up. Now, back to DMARDs for a sec. Methotrexate is mentioned quite prominently. Your notes specifically list who should not take methotrexate.
Yeah, the notes are very clear. Pregnant women must absolutely not take it because there's a very high risk of severe birth defects.
Right.
Also, individuals with pre-existing liver disease or severe blood disorders shouldn't take it.
Right. The contraindication with liver disease makes sense because methotrexate itself can cause liver toxicity, so pre-existing damage just makes that risk much higher. And the link to blood disorders points directly to one of its major potential side effects: bone marrow suppression.
There's that term, again, bone marrow suppression. Can you just remind us quickly what bone marrow makes and what you'd see if it were suppressed by a drug like methotrexate?
Sure. Your bone marrow is basically the factory for all your major blood cells. Red blood cells that carry oxygen, white blood cells that fight infection, and platelets that help blood clot. If methotrexate suppresses the bone marrow, the production of one or more of these cell lines goes down.
Okay, so fewer red blood cells means anemia, right?
Yeah.
Making someone feel tired, look pale.
Correct. Fewer white blood cells is leukopenia, or more specifically sometimes neutropenia. That significantly increases the risk of infections because white cells are your primary defense.
And fewer platelets.
That's thrombocytopenia. Platelets are essential for blood clotting. So too few platelets means an increased risk of bleeding, bruising easily, that sort of thing.
Wow. So methotrexate can potentially hit all three major blood components: anemia, infection risk, and bleeding problems. Given the potential for liver toxicity in these blood issues, drinking alcohol with this drug sounds like a really terrible idea.
It is strongly advised against. Alcohol significantly increases the risk of liver damage when combined with methotrexate. Just don't do it.
Okay. Another DMARD mention is adalimumab. What's its use and the major caution associated with it?
Adalimumab is a type of biologic DMARD. It's used for conditions like rheumatoid arthritis, Crohn's disease, psoriasis, others. The primary caution, the big thing to know, is that it's a powerful immunosuppressant. It works by blocking specific parts of the immune system that drive inflammation.
So while that's great for helping the autoimmune condition, it leaves you more vulnerable to infections, right?
Exactly. Suppressing the immune system means you're at a higher risk of developing infections, and that includes serious opportunistic infections. Those are infections caused by microbes that wouldn't typically cause illness in someone with a healthy immune system.
Which brings us back to that concept immunosuppressed patients are particularly vulnerable. Your notes list examples like people with HIV/AIDS, those undergoing chemotherapy, and people on immunosuppressant drugs like adalimumab, or another one mentioned, cyclosporine. Cyclosporine is another powerful immunosuppressant. Is there a specific food caution with cyclosporine?
Yes, there's a very well-known one. Avoid grapefruit and grapefruit juice. Grapefruit contains compounds that interfere with the way the body metabolizes cyclosporine. This can lead to dangerously high levels of the drug in the blood, which increases the risk of toxicity.
Another really crucial food-drug interaction to remember. Okay, let's hit a few other specific conditions mentioned in your notes, starting with gout. How would someone recognize the symptoms of gout, even if they didn't know the word gout?
Gout symptoms are usually pretty distinctive, often quite unmistakable, actually. You get a sudden onset of excruciating joint pain, often described as severe, maybe crushing along with redness, swelling, and warmth over the affected joint. It feels hot to the touch. It most commonly strikes the joint at the base of the big toe. An attack there even has a specific name, podagra.
So, sudden, severe, hot, red, swollen joint, often the big toe. Sounds pretty memorable. Your notes list allopurinol as a treatment. What is its classification? How does it work?
Allopurinol is classified as a xanthine oxidase inhibitor. Okay, what does that mean? Xanthine oxidase is an enzyme in the body that's involved in producing uric acid. Gout, as you know, is caused by the buildup of uric acid crystals in the joints. So by inhibiting this enzyme, allopurinol lowers the production of uric acid and therefore lowers the levels of uric acid in the blood.
So it's tackling the root cause, the crystal buildup, not just the inflammation of the acute attack itself.
Exactly. The notes mention other drugs for gout too, like colchicine, which is often used for acute attacks, or probenecid, which helps the kidneys get rid of uric acid, and of course corticosteroids for inflammation. What about taking allopurinol? Should it be with or without food?
The notes say allopurinol should be taken with food. Why is that?
It helps to minimize potential stomach upset or GI irritation, which can be a common side effect for some people.
Okay. Are there any really dangerous adverse effects to specifically watch out for with allopurinol?
Yes, the most critical adverse effect to be aware of is a skin rash. Any rash developing while someone's on allopurinol could potentially be a sign of a serious, even life-threatening hypersensitivity reaction. So any new rash needs to be reported to the doctor immediately. Liver toxicity is also a possibility, so monitoring might be needed sometimes.
That rash warning sounds absolutely essential. Okay. Your notes also mention hydroxychloroquine. What's the specific toxicity risk associated with that particular drug?
Hydroxychloroquine, which is sometimes used for autoimmune conditions like lupus or RA, and also malaria prevention, carries a specific risk of retinal toxicity. That means potential damage to the retina, the back part of the eye. This damage can, unfortunately, lead to irreversible vision changes. Because of this risk, people on long-term hydroxychloroquine therapy typically need regular eye exams, often yearly, to screen for any early signs of this toxicity before it causes permanent vision loss.
Retinal toxicity and required eye exams.
Yeah.
It's a very specific and important point to remember. Okay, let's just quickly cover a few terms listed in your notes that are helpful to know when you're reviewing health information. What does alopecia mean?
Alopecia simply means hair loss.
Hirsutism.
That's excessive hair growth, often in patterns more typical for males, like on the face or chest. In women, it can be related to hormonal imbalances.
And paresthesia.
Paresthesia is that abnormal sensation of tingling, prickling, or numbness, often described like pins and needles. We actually saw that type of nerve symptom mentioned as a potential issue with aminoglycoside toxicity earlier, remember?
Right, yeah, connecting back to neurotoxicity. Good point. Your notes also touch on vaccines and specifically the purpose of boosters. Why do we actually need booster shots?
Well, boosters are given after an initial vaccination series because the immunity provided by those original shots can sometimes decrease or wane over time. Boosters act like a reminder to your immune system. They basically re-stimulate the memory cells that were created by the initial vaccination, and they boost the levels of protective antibodies back up. It reinforces your defense against the pathogen and extends how long your immunity lasts.
Okay, so the fundamental principle of vaccines is basically teaching your body to recognize and fight a specific germ without actually making you sick with the disease, right?
Exactly. They introduce a weakened or inactive form, or sometimes just a piece of the pathogen. Your immune system sees this as a threat, learns to produce antibodies, and creates those memory cells specific to it.
So that if you encounter the actual virus or bacteria later on, your immune system has already seen it, recognizes it instantly, and can launch a much faster and stronger defense to protect you.
That's the goal. However, not everyone can safely receive all types of vaccines, specifically live vaccines.
Right. Who should generally avoid live vaccines?
Generally, people with weakened immune systems need to avoid live vaccines. This includes individuals who are immunosuppressed because of conditions like HIV/AIDS, or those getting chemotherapy or radiation that suppresses the bone marrow. Also, people on high doses of immunosuppressant medications like corticosteroids or those DMARDs we discussed, like adalimumab or cyclosporine. And typically, pregnant women should also not receive live vaccines.
That makes sense. A weakened live virus could potentially cause illness in someone whose immune system isn't strong enough to handle it properly. One last vaccine point from the notes, Gardasil. Is that vaccine only for girls?
Absolutely not. That's a common misconception sometimes. Gardasil protects against human papillomavirus, or HPV. HPV can cause various cancers, cervical, anal, throat cancers, and also genital warts, and it affects both men and women. Therefore, Gardasil is recommended for both boys and girls, usually in the preteen years.
Important preventative measure for everyone then.
Mhm.
Okay, finally, just a couple of practical notes from the very end of your material. Applying topical medications, any specific instruction.
Yeah, the standard instruction is pretty simple. Clean the area thoroughly first, usually with soap and water, then pat it dry gently before applying the medication. This just ensures the medication can absorb properly into the skin and isn't applied over dirt, oils, or other residues.
Makes sense. And a question lots of people have about antibiotics. How long after starting them is someone typically no longer contagious? Is there a rule of thumb?
Generally, for many common bacterial infections, a person is considered non-contagious about 24 to 48 hours after starting an effective antibiotic treatment and showing improvement in their symptoms. But, and this is important, this isn't a universal rule. It can vary significantly depending on the specific infection and the antibiotic being used. Always best to check with the provider.
Okay, that covers a truly tremendous amount of material from your notes.
It really does. We've dissected mechanisms of action for different drug classes, identified critical signs of toxicity and side effects, highlighted really crucial patient teaching points for using medications safely. We've explored the why behind things like superinfections and vaccine boosters, and hopefully clarified some key medical terms along the way.
Right. Yeah, we've navigated a really significant landscape in this deep dive, from the fundamentals of how antibiotics and antivirals target invaders, right through to those absolute must-know instructions for taking meds like tetracycline and alendronate safely, to understanding serious red flags like Stevens-Johnson syndrome, or the risks tied to powerful drugs like fluoroquinolones and methotrexate.
We've sort of pieced together how recognizing symptoms of toxicity, knowing about drug interactions, and grasping concepts like superinfection or how bone density is measured with DEXA scans, how all these things contribute to a more complete picture of health management and medication use.
Definitely. The goal was really to cut through the noise, get right to the essential nuggets of knowledge from your sources. We hope this deep dive has given you that valuable shortcut to being, well-informed on these specific topics.
And here's where it gets really interesting, I think. When you consider the sheer volume and variety of potential side effects, interactions, and just individual patient factors we've touched on. I mean, from kidney and ear damage with aminoglycosides, potential liver damage with methotrexate, to that very specific retinal toxicity with hydroxychloroquine. And even things maybe not fully detailed here, like the black box warning for blood clots with certain hormone-related drugs like SERMs. It profoundly highlights just how incredibly complex it is to tailor medical treatment for each unique person.
It really makes you appreciate the constant vigilance and, frankly, the depth of knowledge required in patient care. It absolutely raises that important question. How do healthcare providers constantly weigh the significant benefits of these powerful medications against such diverse and potentially serious risks? Especially when dealing with vulnerable patients like those we discussed who are immunosuppressed, it's just this constant, complex balancing act, isn't it?
It truly is a vital consideration for anyone looking at this kind of material.
Thanks so much for joining us for this deep dive.